to the emergency room complaining of abdominal pain and distension. So please concentrate with me. She is a 70-year-old female, abdominal pain and distension. So this is what she is complaining of. Abdominal pain and distension. So what are the most relevant questions you need to ask? I need 2 questions to be asked at this stage.
The onset?
No, not the details of the symptom. Another 2 symptoms.
Bowel movement?
What else?
Vomiting.
Vomiting.
Constipation.
And constipation. So constipation and vomiting. Why you have chosen these 2 questions?
دكتور أول شيء constipation لأنه في عنا distension الفيسز ممكن من الأشياء اللي ممكن تعمل لي abdominal distension. إذا في عندي obstruction مثلا إذا في عندي obstruction هذا يعمل لي constipation وبالتالي يصير في عندي distension.
طب ليش بتقول مثلا يعني احنا we are discussing intestinal obstruction and we said that we have a patient who is having abdominal pain and distension. So the ones who have answered vomiting and constipation, why they have chosen these 2 symptoms out of all the symptoms that we know? Why these are the 2 most relevant questions?
دكتور
اللي جاوب في زميلة لكم هي اللي جاوبت
To assess the bowel movement. حركة الأمعاء يشوفون إذا في حركة إذا سبب
I'm asking why we have chosen these 2 questions out of hundreds of symptoms.
To narrow down the cause of the distension. If it was intestinal obstruction or not. Or another cause يعني.
Yes.
The cause of distension.
The most direct answer to my question is these are the 4 cardinal symptoms of intestinal obstruction. So once somebody is having abdominal pain and distension, the first thing that will come to the mind is obstruction. And to complete the picture of obstruction, you need the constipation and vomiting. These are the 4 cardinal complaints of intestinal obstruction. Having these 4 symptoms on board, so the next step is what are the relevant bowel symptoms? Bowel symptoms. Of course, once you have obstruction in mind, so we are concentrating on the bowel because it is bowel obstruction.
دكتور ممكن لما نسمع الباول موفمنتس تكون increased.
دكتور احنا شو قاعدين بنحكي هون؟ شو هاي الكلمة اللي عليها الكيرسر؟
symptoms هسه انتبه سوري.
احنا بالهيستوري ماشيين دكتور سيستماتيك مشان نتعلم دائما في الطب نمشي سيستماتيك.
blood and stool maybe دكتور.
نعم.
blood and stool.
blood and stool. Okay. What else? We have symptoms.
Fever.
Cramps maybe دكتور.
ما احنا حكينا pain. The cramps is the details of the pain.
Maybe fever دكتور.
Abdomen.
Gas and bloating. Flatulence.
Gas, bloating. What else?
constipation كونه في
احنا شو
obstruction.
قلنا هون دكتور لما قلنا what are the two answer questions شو قلنا؟
vomiting and constipation.
قلنا vomiting و constipation.
نعم.
Bowel, what do we have bowel symptoms?
loss of appetite
يعني
maybe دكتور.
suppose that this patient has come with intestinal obstruction. There is a good possibility that over the last period, whether weeks or days or few months, he may be having symptoms representing the disease or problem that has ended in obstruction. So obstruction can come without previous problems the patient aware of, or there have been something going on for some time, ended in obstruction.
Cramping.
Doctor, cramping is type of the pain, one type of the pain. احنا حكينا the patient is having abdominal pain. She's having abdominal pain, distension, constipation, and vomiting.
طيب.
ممكن appetite
What?
appetite loss.
Bowel symptoms, bowel.
early يعني early feeling of fullness.
Has there been a change in the number of bowel motions? Bowel motions, bowel symptoms? The patient is presenting now with constipation, absolute constipation. She's not passing. But the patient may tell you that over the last period, I've been noticing a change in my bowel habit. And bowel habit means the number of bowel motions, the stool characteristics, the stool caliber. So we need to know if there has been a change in the bowel motions, whether the number or the characteristics of the stool or change in the caliber of the stool. So the patient may tell you that the stool has become fragmented, the stool has become loose, the stool has become narrower, the number of bowel motions increased, decreased, or alternation between increase and decrease. So we need to know what was the bowel habit of this patient before her presentation. These are the bowel symptoms. Is there blood in the stool? Is there mucus in the stool?
Mucus maybe.
شو maybe?
blood دكتور. نستول.
مش فاهم ايش التعليق.
No, there is blood in the stool.
طب انا عم بحكي يعني من السيمتومز، ما انتم ما سألت ما جاوبتوا، انا بحكي وبحكي بورجي الصورة، بقول the presence of blood, the presence of mucus. ممكن هاي المريضة اللي جاية بintestinal obstruction يقول لك I've been noticing some blood coming through the stool over the last days or weeks or months, or I've been noticing some mucus. طبعا if this is positive there are a lot of questions to be asked after that. The duration of the bleeding, the color of the blood, the relation of the blood to the stool, the relation of the blood to the bowel motions, the amount of blood, so many questions. But I'm asking about the original question, is there blood or not? These are bowel symptoms, you should be aware of these. These are cardinal symptoms of the GIT. What are the relevant defecation symptoms? What can the patient have complaints during defecation?
Pain.
Pain when?
either بالأبدومن أو مثلا like عند الأنس.
اوكي pain abdominal. انا بحب لما نحكي على الانال يعني يعني نحطها في كاتيجوري ثاني اللي هي الانال symptoms بس يعني that's right. So pain. What else? Tenesmus. لحظة شوي.
Straining.
What is tenesmus?
painful defecation وإنه بحس المريض إنه يعني راح على الحمام بس إنه ما أخرجش إشي.
The second part is the right answer. There is a desire but nothing comes out. Painful defecation مش بحاجة أنا أسميه اسم ثاني يعني. Pain is pain. You don't need to use the word tenesmus to indicate pain. So tenesmus is a false desire or a fruitless desire. Yes, so we have pain, we have tenesmus. What else can go wrong during defecation?
دكتور straining.
Straining, yes. What else? So number one is straining. And we are more interested if there has been a change in these symptoms. So the patient tells you that I started to put more effort in defecation, feeling of incomplete evacuation, and tenesmus. So tenesmus, nothing comes out. Feeling of incomplete evacuation, the patient passes some, but he doesn't feel satisfied. Urgency, the patient feels that he needs to go quickly. And feeling of an obstructed outlet, the patient tells you that I feel the stool, I have the desire, I push, but I feel the way is obstructed. Of course, in addition to the pain that you have mentioned. What does these symptoms indicate if they are present?
يعني دكتور في أكثر من شغلة بس ممكن من الأسباب constipation ممكن واحد معاه diverticular مثلا وتصير معاه تنسمس يعني ممكن أكثر من شغلة تخطر على البال ممكن obstruction كمان.
Where is the problem if these symptoms are there? أنا ما بسأل differential diagnosis أنا بسأل pathophysiology.
In the intestines.
واو. وين بالintestine؟
Small intestine.
باللارج.
بالكولون.
يعني معلش اللي جاوب small intestine. If somebody is having a problem in the small intestine, the patient will feel that his outlet is obstructed. How do we feel the desire to defecate? Oh. We feel the desire to defecate when there is increase in the intraluminal pressure in the rectum and the lower colon, perhaps part of the sigmoid, with variability between people. So the intraluminal pressure in the rectum will reach a level because of the accumulation of the stool that will send an afferent impulse to the spinal cord in order to have an efferent impulse to contract the bowel and relax the sphincter if the circumstances are convenient. If not, the brain will voluntarily abort this reflex. So, if there is a problem, pathology in the rectum or near the rectum, the more the problem is near the rectum, the more you will have of these symptoms. Because tenesmus means that there is a desire, but it is not caused by the stool. Feeling of incomplete evacuation, the stool is partly responsible for desire. Straining, there is a desire, but the patient still feels that he needs to push more in order to get rid of this desire. So any pathology in the rectum or near the rectum will give the desire. So in cases of pathology, the desire, the sensation, is not caused by the increase in the intraluminal pressure by the stool. It is caused by the pathology, whether it is inflammatory, infectious or non-infectious, or a tumor, or a problem in the capacity of the rectum. So the more you have defecation symptoms, the more the problem is distal. What are the relevant general symptoms you need to ask about?
Loss of appetite.
Loss of appetite,
weight loss,
loss of weight,
Fever maybe.
fever,
fatigue,
fatigue, pallor. Somebody is coming with obstruction and you find that the patient is pale. Then you start thinking that his problem that has ended in obstruction is causing anemia. And that's where you look for that. Loss of weight and appetite, fever, jaundice. So these symptoms, if they are there for some times before the presentation of obstruction, they might give you an idea about the pathology or the severity of the pathology. For example, the more you have fever, the more you think that this process is inflammatory or infectious. The loss of weight and cachexia means that the process has been there for some time. What do you want to ask in the past medical history?
Any
Past
past
Previous surgery,
previous occurrences للهاي إنه الobstruction.
similar condition. لا تقول للobstruction، احنا لسه ما حكيناش obstruction، احنا قاعدين بنحلل.
إذا كان عنده past medical history of hernia maybe or
Hernia. So surgery is important. Hernia is important. Tumors are important. Why the surgery is important?
مشان ممكن تعملنا adhesions و adhesions can cause intestinal obstruction.
Yes, so surgery may be related to adhesions.
دكتور كمان ممكن السيرجري تسبب لي هيرنيا اذا صار في ديفكت بالوول.
وممكن السيرجري تعمل هيرنيا. والتيومرز شو علاقتها؟ Why the past history of tumors is important.
Maybe compression على ال intestines.
يعني the tumors will cause the obstruction مش بالcompression يعني mainly. It's a tumor, it's an intraluminal lesion. The tumors are basically intraluminal. They will close the lumen. رقم 2 بيجي if there is pressure from the outside. Tumors can cause adhesions as well. So the surgery is important because it may include adhesions or hernias. Hernias are important, whether femoral or inguinal. And tumors are important because they may represent the cause of the obstruction, whether directly by the tumor itself or the reactions around. And any surgery is important, whether laparoscopic or open, whether there are stomas or no stomas. So these are the most important points in the history of such a patient. This will not replace a complete history, but I'm mentioning the relevant things that are directly related to the obstruction. How do we embark on the evaluation of this patient? Suppose you had taken this history from this lady and she is lying in front of you in the bed. How will you proceed with her evaluation?
دكتور يعني أول إشي ممكن أعمله inspection، ممكن يبين معي ماس بمكان معين قبل ما أبلش أي إشي، يعني قبل ما أبلش مثلا الاسكالتيشن، أشوف الباول موفمنتس أو أي إشي.
Any other suggestions?
إذا بدي أتأكد في هيرنيا ولا لا، ممكن من الكفنج أحكي لأنه
any other suggestions? When you learned about the examination of a patient, they taught you to start with the abdomen?
General.
نشوف لو في عندها
General examination.
So?
Looking for pallor and jaundice. Vital signs.
You are thinking of obstruction. A patient of obstruction, نحكي على acute intestinal obstruction, this is an emergency. The patient with obstruction is dehydrated by default. And this may be severe enough to cause shock. The patient may be shocked or an impending shock. Intestinal obstruction causes sepsis. So the vital signs. Then the general examination, ورجيناكم الصور, pallor, jaundice, the general look, how the patient is lying in bed, is he in pain or comfortable? Is he moving in the bed or cannot move? So the vital signs and then the general examination. What do you want to examine in the neck?
ممكن lymph nodes.
Lymph nodes. eye lymph nodes. What sort of lymph nodes do we have in the neck?
دكتور الليمف نودز اللي موجودة عند السبكليفيان فين اللي بصب فيها اللونج ثوراسيك عشان بتسحب الليمف من الانتستلز ممكن تصير ميتاستاسيز.
شو اسمها هاي الليمف نود اللي في المواصفات اللي بتحكي عنها؟
فيرشو ناس فيرشو يمكن.
طب by position where it is present? This is a supraclavicular lymph node or Virchow's lymph node. But all the lymph nodes are important and may be related to the abdomen. So even the cervical lymph nodes are important. But this is famous because of its relation to intra-abdominal malignancy. Not only gastric cancer, all the intra-abdominal malignancies. That's why it is always mentioned in intra-abdominal problems. And since we are including intestinal obstruction in, we are including tumors as a possible cause of intestinal obstruction. What do you examine in the abdomen of this lady?
We look for masses.
لو في scars.
So you start looking for masses. احنا تعلمنا بالabdominal examination we start by palpation for masses.
دكتور انسبكشن من الفوت من اوف ذا بيد بنشوف اذا في سيمتري او لا سيمتريكال ولا الابدومين.
Okay.
نشوف إذا الأمبليكس is everted أو لا.
Okay.
لو في dilated veins أو لا.
بنشوف if the abdomen moves with breathing.
Moves with respiration. What is very much relevant to intestinal obstruction out of these symptoms? Very much directly related. يعني dilated veins إذا بدنا نجد علاقة راح تكون غير مباشرة بنقول dilated veins is part of this and يعني بس إحنا بدنا شيء مباشر يعني telling you that this is obstruction or cause of obstruction.
Maybe swollen belly.
نسميها distension مش هيك؟
Distension.
مش المريضة حكت بالهيستوري عندي distension؟ بدنا نعرف what does the patient mean by this distension? Because people mean different things when they say distension. So you want to know if the abdomen is moving with respiration, because the absence of movement means what?
Peritonitis.
Irritation of the peritoneum. Because when the patient takes respiration, whatever is irritating will be more in touch with the peritoneum. You ask the patient to cough. Again, if the patient develops pain, معناته this cough has caused irritation of the peritoneum by the irritating cause. You look for scars. You look for hernias. What do you palpate for?
We palpate for masses or tenderness.
أنا كنت بفضل تبدو بتندرنس. وبعد التندرنس إيش بيجي؟ بيجي guarding. بعد الجاردنج إيش بيجي؟ بيجي rigidity. So if somebody is not moving his abdomen with respiration, he develops pain on coughing. When you palpate his abdomen, there is tenderness and guarding and rigidity. What does all that mean?
ممكن if they're guarding that means that they're in pain or they have
All that means peritonitis. It can be localized or generalized. It can be mild or moderate or severe or board-like rigidity, depending on the irritating cause and site and severity. This is very much important in obstruction, because one of the most fearful things in obstruction is the development of peritonitis, because this means a complication of the obstruction. If there is distension, you need to know by palpation, is this distension gas or fluid or mass? And you need to identify where is the distension. Is it a diffuse thing or a localized thing? You hear the bowel sounds. Whether it's increased or decreased, both are important in obstruction. So you look for distension. And you differentiate between a diffuse distension like this and a localized distension like this. See the difference between this area of the body, of the abdomen, and this area and this area. This is fat, by the way. It's clear that the distension is high up. And if you measure the distance between the xiphisternum and the umbilicus and the umbilicus and symphysis, you will find that as if the umbilicus is shifted downward. The umbilicus does not shift, the umbilicus is fixed, but the area above it is distended. That's why it looks like the umbilicus is shifted. عشان هيك تعبير the umbilicus is shifted downward هو تعبير مجازي. It means that the upper part is distended. So there is a difference between this distension and this distension and this distension. See the difference between the upper abdomen and the right side and the left and lower, which is collapsed. So this distension here may be small intestinal distension, because the small intestine is diffuse, may be fluid, but this is a stomach distended. And this is a right colon and transverse colon distension. You look for masses, and if there is a mass, you need to describe it with all the descriptions you have been taught about: the site, the size, intra-abdominal or extra-abdominal, mobility, tenderness, etc. Signs of peritonitis. This is pus in the peritoneum. Tenderness, guarding, rigidity, وقبل ذلك moving with respiration, pain on coughing, and whether this is localized or generalized. Hernias, and you decide what is the type of the hernia, and is the hernia complicated or not complicated? For a hernia to cause obstruction, it needs to be complicated. And what are the findings to suggest complications of a hernia? How do we know if a hernia is complicated? Hello?
دكتور ممكن إذا صار obstruction، طلع جزء من الانتستنس وعلق هناك صار obstruction.
يا ابني أنا سؤالي عن هيك. If it is complicated, what are the signs, symptoms and signs that indicate that this hernia is obstructed? The complications of a hernia is obstruction and strangulation. What will the patient have? طب أنا برجيكم الصورة.
نفس الساينز والسيمتومز اللي حكينا عنهم للobstruction، راح يجي عندنا distension،
يا ابني
راح يجي
احنا بنحكي على الهرنيا نفسها. What do we have change in the hernia?
بيصير irreducible.
There's
Irreducibility.
swelling, discoloration.
So the first thing that the patient will notice is pain in the hernia. It becomes irreducible. If you examine it, you will find that it is red, tender, and of course irreducible. So as you see here, this is an uncomplicated hernia. This is a red hernia. If you examine this one, you will find that it is tender. How can we examine for irreducibility? So how do we examine for irreducibility? Wow.
إنه كيف نعرف إنه الهرنيا
So how do we
reducible؟
examine for reducibility?
آه
يا جماعة
إنه
شو شفتونا سوينا؟ احنا هلا شو سوينا بالفيديو؟
نجرب نعملها بالبيت إنه إذا
الله أكبر. انت شفت palpation بالفيديو؟
We ask the patient to cough and see.
الله أكبر. الله أكبر. So you ask the patient to cough. The hernia will appear and then it will reduce. Irreducibility means that the contents are fixed. It will not increase on coughing. It will not reduce after that. So this is how we examine for a hernia. This is a reducible hernia. بالمناسبة حتى اللي شفتوه هذا لو ضغطنا عليه بفوت جوا، يعني المريض بكون عنده بس سكار زي المريض هذا بس عنده سكار. لما قلنا لها قحي وبانتهاء الكوفينج it will reduce. In addition to what you see redness and the tenderness, etc. So these are the indications of a complicated hernia. So out of the general examination, the vital signs, the general examination, the head and neck, the chest and the abdomen, you need to come out with conclusions. Number one, you prove that the patient is having obstruction. You need to know if the patient is having peritonitis or not. Is he having masses or not? And before that, what is the degree of dehydration? What is the degree of shock and sepsis the patient is having? What is going to determine the management and the outcome of obstruction is the shock and sepsis. So we divide intestinal obstruction into dynamic and adynamic. In dynamic, there is mechanical obstruction, and the intestine starts moving against that obstruction. That's why the patient will have the colic. That's why the bowel sounds will be increased. That's why sometimes you can even hear gross sounds, because the bowel is contracting against obstruction. The adynamic, there is no mechanical obstruction. The peristalsis is absent or inadequate because the original problem is immobility. So although we don't have mechanical obstruction, we consider that the patient is obstructed because the contents of the bowel are not moving. So the bowel is not doing its job, whether absorption or motility and movement of the contents. It can occur in the small intestine, we call it paralytic alias. It can occur in the colon, we call it pseudo-obstruction. In the mechanical obstruction, the proximal bowel will dilate. While the distal bowel will continue to move and continue to pass contents till it empties and collapses. What is the importance of this statement? The presence of bowel sounds will not rule out obstruction, because the patient can be completely obstructed, but still pass some motions from the distal bowel. And the number and amount of stool passed will depend on the amount of stool we have distally. So the more the obstruction is proximal, the more you will have passage of stool. So you can have a patient who is totally obstructed, but still may pass some bowel motions till he empties the bowel. Initially, the proximal bowel will contract, will have peristalsis against the obstruction. That's why the bowel sounds will increase and the patient will have cramps. However, after some time, when the small bowel becomes ischemic, the motility will stop and the bowel sounds will be absent. What is the importance of this? If there is a patient who is obstructed and he is no more having bowel sounds, you should not be happy. On the contrary, this is a grave, because it means that the bowel is ischemic and perhaps dead. Why do we have distension proximal to the obstruction? What is the cause of the distension? What do you think? There are two factors. Number one is the gas, and the sources for the gas is or are swallowing and overgrowth of aerobic and anaerobic bacteria in this stagnant fluid. And the other factor is fluid. Even if the patient is not eating or drinking, still we have good amount of bowel contents. Saliva, around half a liter. bile around half a liter, pancreatic secretions around half a liter, gastric contents around a liter. So you have 2 to 3 liters of fluids poured in the intestine daily, even if you don't eat or drink. And these are reabsorbed by the intestine. When there is obstruction, the function of the intestine will be impaired and the absorption capacity will be impaired. So the fluid will accumulate. And this accumulation of gas and the fluid is the source for what you hear about air fluid levels in obstruction. Proximally, there is accumulation of the fluid, of the gas and the fluid, and this gives the air fluid level appearance on upright film. And this causes the distension that you see clinically and you see on recumbent or lying plain abdomen. Accordingly, every patient with obstruction is dehydrated and having electrolyte and acid-base defects because the patient is not taking orally, the intestine is not absorbing, he may be vomiting. So we have a lot of fluid present in the bowel lumen. Not only that, when the integrity of the bowel wall is affected, you start having leaking of the fluid the other way around, from the intestine to the peritoneal cavity. That's why when we open a patient with obstruction, we find the fluid in the peritoneal cavity. So by default, they are dehydrated. And this sequestration of fluid in the bowel lumen is an example of what we call the third space loss. The patient is dehydrated, although the fluid is not lost outside the body because it is in the body, but it is not in the intracellular or intravascular or interstitial compartment. It is present in lumens or peritoneal cavity. Any patient who is obstructed will accumulate gas and fluids, as we have mentioned. This will raise the intraluminal pressure, and this may reach the venous pressure. Accordingly, you have more congestion and decrease in the function of the wall, and the intraluminal pressure ultimately will reach the arterial pressure, and the intestine will become ischemic. But this process will take some time because the lumen is having the capacity to dilate and accommodate. However, this change from normal to ischemia can be quite quick in certain types of obstruction. Basically, if there is a strangulation, which means that the blood supply to the intestine is cut from the start by the cause of the obstruction. And this is a life-threatening condition. The bowel will soon become ischemic. Patient will have peritonitis and sepsis and circulatory failure in a short period of time. It is just like cardiac ischemia or lower limb ischemia. Another type of bad obstruction is the closed loop obstruction, when the bowel is obstructed at two sites. Accordingly, this loop in between will not have a lot in the capacity of dilatation and accommodation. That's why it will go into ischemia soon. And sometimes the obstruction will cause both strangulation and the closed loop at the same time, which is the worst type of obstruction. And this can occur in hernias, some types of adhesions and bands, volvulus, and intussusception. So look at this small piece of bowel, which has been trapped in a hernia. It is obstructed at two sides with some cut of the blood supply. Soon it will become ischemic. Look at the proximal bowel, although it is obstructed, but still it is healthy because it has enough time and capacity to dilate and accommodate. But this piece is strangulated and obstructed at two sides. So it gets ischemic soon, few hours. It will end up with gangrene like this. And this is the most fearful thing in obstruction, to end up with gangrene. Of course, after gangrene is perforation and peritonitis, generalized peritonitis. So your duty as a physician is to prevent this to happen. Diagnose, resuscitate, and to prevent this. After this overview of what do we mean by obstruction, the pathophysiology, associated problems, we will go into a tour of the causes of obstruction. So we start with small bowel obstruction. What do you know causes of small bowel obstruction?
Adhesions,
Adhesions,
strictures,
strictures needs a cause. ما في شيء اسمه stricture هيك لحاله يعني في
maybe,
cause.
maybe from Crohn's.
Crohn's.
Hernias.
Volvulus.
Volvulus is basically a colonic problem. It can occur in special cases in small bowel, but basically it's colonic.
Intussusception, maybe.
Intussusception.
Hernias.
Hernias.
Volvulus.
ما حكى volvulus وقلنا volvulus is basically a colonic one. It can occur in special circumstances in small intestine.
ممكن tumor.
Tumors. So it's nice that you have mentioned the common causes of obstruction, because many of the students, when I ask them about causes of small obstruction, they mention the quite rare things, causes. So yes, adhesions is heading the list. Hernias, tumors, strictures like Crohn's, and rarely TB, and intussusception. We have rare causes, basically intraluminal ones, like gallstones, foodstuffs, trichobezoars, phytobezoars, stercoliths, and worms. These are rare. I haven't seen any of the worms or stercoliths. Maybe I've seen once trichobezoar. Gallstones, every 2-3 years I see a case. But in every night there is a case of adhesive obstruction. So just to give you an idea about what do we mean by these rare things, before we concentrate on the common ones. So these are boluses of hair, and this is what we mean by trichobezoar. Some mentally deranged people they eat hair, and the hair accumulate and get stuck somewhere, like the pylorus. So you see the stomach full. It's taking the shape of a stomach. Sometimes it passes and gets stuck in the small intestine. This is a rare cause. Phytobezoars, certain types of food. For example, this fruit is not present in our part of the world. لكن عندنا احنا مثلا اشي مشابه اللي هو الصبر. It may accumulate before a narrowed area. So if somebody is having narrowing somewhere in the small intestine, it may accumulate. Or the fibers of orange, for example, may accumulate in front of a narrow area. These are quite rare. Gallstone alias. You keep hearing about this, and people think that the gallstone will pass through the cystic duct to the duodenum and then to the small bowel, which is not the case, because the stone that passes through the cystic duct will not cause obstruction of the small intestine. When there is gallstone alias, it means that the stone has eroded through the duodenal wall through a cholecystoenteric fistula. That's why it's quite rare. It passes through the duodenum to the small intestine, and it will get stuck somewhere before the terminal ileum, which is the narrowest part. And these are examples of a stone in the small intestine. And this is after it has been opened. This is how it appeared on a CT, and this is how it appeared on plain X-ray. It's a rare problem. So when you are asked about a small intestinal obstruction, don't mention these, or don't start with them at least. You have to start with the common ones. This is one common cause, not the commonest, of a small intestinal obstruction, which is a Crohn's disease. So this is the terminal ileum, this is the appendix, and this is the cecum. As you see the difference between this inflamed part and this normal part of the small intestine. This is quite inflamed. The fat is creeping in order to heal and seal. See, the inflammatory process has reached the surface. That's why it presents with a picture similar to appendicitis, because it's an inflammatory process near the appendix. And you know that the terminal ileum is the commonest site. Crohn's can cause obstruction in two ways. In the acute phase, like this, by the edema and the inflammatory process. And this is the type of obstruction that can be resolved with the treatment of inflammation. And this is what you see in medical treatment: NPO, IV fluids, steroids, anti-inflammatory agents, till it resolves. However, if this repeated, with every attack it heals by fibrosis, this is another example of the inflammation in the terminal ileum in a patient with Crohn's disease. And easily you can differentiate between the inflamed terminal ileum and the normal bowel. And this is a severe form of inflammation. If there are repeated attacks, the bowel will end with fibrosis and stricture. And this type of obstruction, the fibrosing type of obstruction, will not heal by the medical treatment. And these are the cases that need surgery. And this is an example of an enterocutaneous fistula caused by Crohn's disease. And this is an abdominal wall abscess. Once you open it, the fistula is created. The commonest perhaps is the adhesive obstruction, and the commonest cause for it is post-operative. It can be fibrinous, which is tiny, زي العنكبوت, or with time it becomes fibrous or thick. The more the bowel is manipulated, the more sutures are used, the more we have peritonitis, the more there are inflammatory reactions because of the disease itself, the more we get adhesions. The fibrinous ones, the early ones, may resolve spontaneously. The bowel movement will overcome these. But once they are fibrous, they will not resolve. But it is not necessarily going to cause obstruction. So you may have a lot of adhesions without obstruction. You may have one band and it causes obstruction. They are not all post-operative. There are some congenital bands. So this is a laparoscopic view. And these are what we mean by adhesions. Some of them are fine, some of them are thick. And these are adhesions, and the bowel and omentum are stuck and amalgamated with it. This is an isolated band. And imagine that this loop, during contraction, it comes underneath. It will become obstructed at two sides. It's going to cause a closed loop obstruction in it. And this is a Michels with a congenital band. Again, this is a congenital band. And this is one of our patients. You see the band is compressing the bowel, obstructing it, and even it starts to strangulate it. See the difference in the color between the strangulated and the healthy bowel. All what we did is we cut this band, we waited, and the bowel returned to health. And this is another patient, but this adhesion, one of our patients, a closed loop has occurred here. The bowel is obstructed at two sides, and this can quickly end up with strangulation. See the difference between the collapsed distal bowel and the dilated proximal bowel. And you can see the difference between this color and this color. Intussusception, which is telescoping, or one part of the bowel goes into the proximal one, can occur in children, can occur in adults. Now in children, usually it's a primary. We don't find a cause in the bowel. In adults, it is usually secondary, which means that the bowel is having a nidus of pathology. It can be alveocolic, alveoleal, or colocolic. So this is what we mean by intussusception. This bowel goes into the one distal to it, or this. The word telescoping comes from the old telescopes. بتشوفوهم زي البحارة. If in one tube goes through the other. And these photos will explain it more. This is the bowel that has gone through the one distal bit, has reached here. So what we do, we keep pulling till it is out. When we say secondary, it means that there is a pathology in this bowel that has gone through the one proximal distal. And this is another example of this bowel which has reached even here. Again, this is the bowel that has entered, and we pull it out. Again, this is the bowel, and it has reached here. In this patient, the diagnosis is a bit late, and we are having dense skin. And this is an ultrasound showing both the bowel that has entered and the bowel that had received intussusception. Again, this is a CT scan showing this bowel, inside this bowel, and these two lumens, and this ileocolic bowel intussusception has reached the transverse colon, and this is a cut that has showed the intussusception. And this is through the colonoscope where we have seen the small intestine inside. Now, the secondary causes can be any disease in the small intestine. Benign ones like Crohn's, lipomas, urofibromatosis, endometriosis, Becker's diabetes, or any malignant lesion like lymphomas or adenocarcinomas, etc. In practice, I have seen it in Crohn's disease. I've seen it with lipoma. I've seen it with Becker's diabetes and with lymphoma. Another cause for small intestine is tumors. People tend to forget the tumors as a cause of small intestine because they are much rarer than colonic. But you can have all the list of tumors in the small intestine. Adenocarcinoma, lymphoma, carcinoids, stromal tumors or guest tumors, or benign ones, adenomas, lipomas, whatever omas. And this pie represents the percentages of small intestinal tumors. So these are the adenocarcinomas, and these are the neuroendocrine tumors, including carcinoids. These are the sarcomas, which we call the gastrointestinal stromal tumors, and these are the lymphomas. And these photos show different tumors in the small intestine. Perhaps this is an adenocarcinoma. This is taken from a capsule, small intestinal capsule, maybe a carcinoid. This is a lymphoma. And this is in the terminal ileum, perhaps lymphoma, other lesion, old pathology specimen. Or this is a small intestinal tumor. Again, from the capsule. Is most likely an adenocarcinoma. And this is how the tumor has reached the surface of the bowel. Hernias are common causes of small intestinal obstruction, not related to the size, can have drastic effects with a small hernia, and you can live with a big hernia. And I've shown these, the difference between an uncomplicated and complicated hernia. See how it is red. If you examine it, you will find that it is irreducible and tender. Same with this one. We have parastomal hernias as well. And this is a CT showing a hernia which is obstructed, and you can see dilated bowel. Hernias are not always to the outside. We can have internal hernias. This is one of our patients. He's having malrotation of the bowel. This is the left side of the abdomen, and this is the cecum and the ascending colon, freely mobile because of malrotation. All what you see here is a hernial sac containing bowel, and the patient presented with obstruction. So you can have hernias internally. واللي حكوا على الانتصسبشن قلنا الانتصسبشن is usually colonic, لكن in cases of malrotation you can have volvulus. You can have volvulus of this, whether the colon or the small intestine. After this tour in the small intestinal causes of obstruction, we can talk about the large bowel. So what do you know of causes of large bowel obstruction?
Tumors, maybe.
Tumors.
Volvulus.
Volvulus.
IBD.
Inflammatory bowel diseases.
Megacolon, maybe.
Megacolon.
Tumors.
ما بدينا بتيومرز.
Diverticular
Tumors.
disease.
Diverticular disease was not mentioned by you. Inflammatory bowel diseases, volvulus, anastomotic obstruction, fecal impaction, ischemic colitis. We mentioned pseudo obstruction, Hirschsprung disease, and megacolon. So tumors, it's clear that fungating or stricturing a tumor can obstruct the lumen of the colon. And if you look here, you find that there is obstruction here and dilatation proximal. Again, you see how the colon is obstructed here and here and here. And this is intraluminal view of how the colon is obstructed by a tumor. And this thing is a stent that we sometimes use in order to open the lumen and relieve the obstruction, although this will not treat the cause, but it will relieve the obstruction. Volvulus, it is a twist. The commonest site is the sigmoid, where there is anti-clockwise rotation against a long mesentery, long narrow mesentery. This is one of our patients. This is what we have found when we open the abdomen. Now what we are going to do is to relieve the volvulus, and then we will demonstrate how does it happen. You see the severe dilatation of the colon, the sigmoid. هلا احنا عملنا ريليف او دي روتيشن للسيجمويد بحيث نرجع الكولون لوضعه الطبيعي ان بوزيشن، بس مش راح نرجعه هلا من ناحيه السايز. فهذا الوضع الطبيعي. هاي هون الديسندنج كولون المفروض هون، هاي السيجمويد، وهون بيبدا الريكتم. هلا بدنا نورجيكم كيف بصير الفولفولس. This is what we mean by volvulus. طب هلا لاحظوا, where do you think the patient will have his distension more in cases of volvulus? Which part of the abdomen? And suppose that the dilatation increases more, where will the increase be?
Right side.
Yes, right and upper. كل ما زاد الدايلاتيشن كل ما حيكون وين؟ Right upper, because that is the site of the dilatation of the sigmoid. لأنه الناس ممكن ما تتخيلش كيف السيجمويد يعني will cause the distension right. Because this is the position that occurs in volvulus. هاي اطلعوا عليه وين الجهة الأكثر؟ على الرايت. وكل ما زاد كل ما اتجه أكثر باتجاه the right and the upper. بينما بنتوقع المنطقة هاي تكون more empty. We like to deflate these by the colonoscope in order to do the surgery, not emergency, and the bowel is clean. But sometimes we are obliged to do it surgically right from the beginning. And this is the resected sigmoid. And this is why they call it the coffee bean sign, because it represents the two loops and the two walls. Another example. Again, this shows how the left side is a bit depressed compared to the right side. Look at this depressed left. And these are CT scan views showing the dilated sigmoid. And this is a late presentation with dead sigmoid. And this shows the twist in the root of the mesentery. Again, look at the dilated bowel. That's why when we say we like to deflate it, because we don't want to do surgery in the presence of this loaded colon. And this is the mesentery rotated. The other cause for obstruction is diverticulitis. And what we have mentioned about Crohn's applies here. It can cause obstruction acutely by the edema and the inflammatory process, and this may be treated medically, but repeated attacks will end in fibrosis and stricture that will need surgery. Again, this represents how there is a cutoff in the descending colon. Another cause is fecal impaction, where the rectum and part of the sigmoid is loaded with very hard feces, and there is dilatation proximal to it. We see it in mentally retarded patients, in nursing homes, receiving psychiatric drugs. And any of you in the future who's going to work in a hospital draining an area where there are nursing homes will see many of those patients with fecal impaction. Pseudo-obstruction is the functional type of chronic obstruction where there is no mechanical obstruction, but the colon is not working. It is similar to the paralytic ileus that occurs in the small intestine. Few words about the vascular insults, because we consider it a type of intestinal obstruction. The bowel is ischemic. It is not contracting. It is not functioning. Mesenteric ischemia refers to a problem in the superior mesenteric system, whether artery or vein or non-occlusive when the heart is not pumping. Arterial obstruction due to thrombosis or embolism. Venous obstruction due to the factors that causes venous obstruction, like the DVT causes. Non-occlusive, very tired hearts. Any ischemia to the superior mesenteric system will end up with gangrene and necrosis in the small intestine because the collaterals cannot compensate for the ischemia. The patient will have few hours to be dealt with. If we don't tackle it, the patient will end up with ischemia. While when the inferior mesenteric system is involved, we call it ischemic colitis because it supplies the left colon. Now, the outcome here will depend on the collaterals. It may save the patient partially or completely, or will not save him, just like the coronaries, the collaterals in the coronaries. If it happens and the patient survives, it may end up with a stricture because of the ischemia. So it is one of the causes of strictures of the colon. These are CT scans of patients with superior mesenteric artery occlusion or the mesenteric ischemia, dilated loops, gas in the portal system. All the gas that you see here is in the bowel wall because of the ischemia, just before the perforation. So, when we say acute intestinal obstruction, we are talking about a very variable presentation or clinical scenario. From the causes that you have seen, we are talking about very much different things. There is a difference between superior mesenteric artery occlusion and intussusception and hernias, etc. What is common to them is the first presentation, pain, vomiting, constipation, and distension. What is common to them is the end result of dehydration, hypokalemia, acid-base imbalance, renal failure, ARDS, sepsis, and death. But what is in between will vary much depending on so many variables and factors. Is it acute, chronic, or acute on top chronic? Is it complete or incomplete? Where is the obstruction? What is the cause of the obstruction? Is it simple or strangulated? Is there associated peritonitis or not? So these are very variable factors. That's why the presentation is so much different and the management is different according to these. However, the general principle is to evaluate the hemodynamic stability of the patient, to resuscitate the patient, and G-tube, oxygen, and then decide and work accordingly. There is a difference between the management of mesenteric ischemia and the management of strangulated hernia or simple adhesive obstruction. So resuscitation and resuscitation and resuscitation till stabilization. Monitoring, urine output, maybe central line and G-tube. Most of the patients will need an intensive management. And as you have seen, most of the cases will need surgery. When will depend on the cause. So you may need to do it acutely, emergency, like ischemia. You may do some resuscitation and surgery. And in simple adhesive obstruction, non-complicated, you may have sometimes to resuscitate the patient more and do it more easily. But of course, you are not going to sleep on any patient with obstruction. All what we have talked about is related to the adults. In the pediatric age group, there are special situations that will be dealt with by the pediatric surgery course or through the pediatric surgery course, whether hernias, the intussusception in children, hypertrophic pyloric stenosis, hair-sprung disease, duodenal atresia, etc. Any question?
يعطيك العافية دكتور.
الله يعافيكم، بس لازم يكون في يعني أسئلة. Any question?
دكتور ممكن سؤال؟
طبعا.
هسا متى حالات اوبستراكشن ممكن يطلع عنا ميوكس مع الستول مش بلود؟
اللي حكينا مش انه السيمتوم ناتج عن الاوبستراكشن. احنا حكينا اذا مريض صار عنده او كان عنده history of blood and mucus، ممكن الكوز of obstruction inflammatory bowel disease or tumor. عرفتوا الفكرة؟ مش الميوكس symptom للobstruction، it is symptom of a disease that has been present for some time that has ended in obstruction. احنا الهيستوري اللي بناخده عشان نعرف اذا في كوز معين ممكن احنا نستدل عليه من خلال الهيستوري.
تمام، يعني كنا نحكي in general السيمبتومز
مش in general.
مش
related to
related.
يعني احنا لما نقول change in the bowel habit ودايريا او constipation، طب ما هو المريض اللي عنده acute obstruction عنده absolute constipation، بس شو كان عنده قبل ذلك؟ ممكن كان عنده symptoms of tumor او symptoms of diverticular disease.
طب دكتور ممكن النيو بورنز يكون عندهم مثلا congenital abnormalities، يصير عندهم obstruction، ممكن ما يبين معنا على طول، ممكن يبين لقدام انه ما يكون
طبعا all the causes I have mentioned كلها لها timing، في شيء 6 weeks، في شيء up to 2 years، في شيء any time. طبعا.
تمام، يعطيك العافيه دكتور.
الله يعافيك. يعني الكونجينيتال ديسيزز مش انه لما بنولد الواحد يعني شرط انها تكون عنده البرزنتيشن. في مرضى ميكلز دافرتيكولم بيجوا بعمركم. حتى الهيرشبرانج في ليت برزنتيشن اوف هيرشبرانج ديسيز. Any question? المفروض احنا اليوم يكون عندنا محاضرة، بعرفش خبروكم؟
إن شاء الله الساعة 3.
إذا خليناها 3:30 في مشكلة؟
والله يا دكتور السي ار باسل هو اللي عنده المعلومات أحسن، لأنه في جروبات عليها راوندات.
أوكي خلاص، معناته خلينا على اللي اتفقنا عليه الساعة 3، بلاش نعمل إرباك.
يعطيك العافية دكتور.
شكرا لكم، بالتوفيق.
يعطيك العافية دكتور.
الله يعافيكم. أهلين.